But whenever you go from the normal path to you deviate it a bit towards some other direction, that means we say that the person is going off track, right? So when a person departs from his usual normal behavior and starts having some sort of an abnormal behavior, that means he's going off track. Okay, that is when we call this as delirium. So what is it? Like I said, it is a behavioral abnormality. What is it? What happens over there? There is an acute confusional state. What do you mean by acute? Sudden onset, right? Acute means sudden onset. Now, in terms of delirium, sudden onset does not mean that in 1 minute you are okay and the next minute you develop a problem. It can be a few hours, okay? Within a few hours you develop an abnormality, or it can even be a few days. In this setting, as far as delirium is concerned, we will term this as acute. So an acute confusional state. But many a times we also go into some sort of confusion, right? The moment we wake up from sleep, many a times we are in confusion. All right, if something, some abnormal situation happens, suppose there is a sudden loud sound or something like that happens, suddenly we may be confused for some time that, oh my God, what is happening right now? You're not sure. So does that mean that we are in delirium? Definitely no. So it is an acute confusional state which is associated with a medical condition or intoxication, or there was some sort of, the person was used to taking some substance, maybe tobacco, it may be some drugs, it may be alcohol. He stopped it and now he is withdrawing from it. So when such situations happen, there will be an acute confusional state and we'll say that the person is in going in for delirium. So what is confusion basically? Confusion is a mental and behavioral state of reduced comprehension, coherence, and capacity to reason. Let me simplify it for you. Comprehension means understanding. Coherence means he is not able to relate to what is happening around him. It may be daytime, but he is thinking that it is nighttime, or it may be nighttime and he is thinking that it is daytime. So he is not in relation to outside world. He is in a different state of his own, and he is beyond a capacity to reason. Right? You may try to make him understand that no, this is daytime. What are you saying? You can see the sunlight. You can see this, but he will not understand it. He will say something which is beyond. You are not able to reason with it. So it is a mental and behavioral state of reduced understanding, okay, and any capacity to reason. So what are the features? Basically, there are 4 features, okay. We'll be looking into it in detail, but right now let's look at this. There will be some sort of prodromal symptoms. Do you know what prodrome means? For example, before you get any viral fever, you know that there will be some 2 days before that you will start feeling very tired. You'll start feeling maybe nauseous. There'll be some symptoms like that, which in general you start feeling, oh, I'm not feeling well, something is wrong, maybe I'm going to get a fever. Similarly, there is a prodrome which can happen for before a person develops this acute confusional state. What are those prodromes? Restless. He'll be very restless. He may be irritable. He may have sleep disturbances, unable to sleep during night time. He may show some sort of aggression or anger, etc. So some prodrome symptoms may be there. Next is it's a fluctuating course. That is, it's not necessary that he'll continuously be having abnormal behavior. There may be periods of time when he is having normal behavior. So you will think that, oh, this guy is okay. There is no problem with him. But after 2 hours, when you go and see, he'll be having some abnormal behavior. So it will keep on having that fluctuating course. So up and down, it's called as waxing and waning, right? Waxing means the symptoms increases and waning means it decreases. So there will be a fluctuating course. The person will have disorganized thinking. He's not sure about, his thinking won't be in the right sense. We'll be looking into it detailed. Incoherent speech, we are not able to understand what he is saying. Irrelevant talk may be there. He will have a reduced attention span. One moment he'll say that he is feeling hungry. The next moment he will say that he's not feeling hungry. Third time he'll say something else. Like completely unrelated topics, he will keep talking. So there's basically a reduced attention span. Increased or decreased psychomotor activity. Psychomotor means one is too much mental activity or very less mental activity, and motor means physical, right? Motor abnormalities may be there. Maybe he'll just have some abnormal movements of his hands like this, or he may just do some picking behavior, like some picking things he's picking from the air, or if he's wearing some clothes, he may just keep pinching on his clothes, something like that. Some abnormal motor behavior will be there. Then affective symptoms. Affect means it is emotional. So there is some feelings inside him. He may show anger, he may show fear, he may show some sadness, he may cry. So basically, emotional instability. Apart from this, many a times you will see that the person is angry, very agitated. He may have some violent behavior. He may abuse you, because of which you will get angry on them, and you end up tying their hands and legs, or you will tell the doctor, please give something to this patient so that he's sleeping most of the time. Have you had such experiences? Aggressive, angry patients, which has developed over a period of few hours or a few days. And apart from that, there will be altered perception. Perception basically means that what are you seeing or what are you hearing? Sometimes you may see or hear things which are not a reality, which is just an illusion. This is what we call as hallucinations. Now, out of all these features, there is one hallmark for delirium, that is attention deficit. You may have asked the patient one question. For example, who is the patient, who is sitting with you, taking care of you in the hospital right now? And before he's able to answer that, he may just start talking some other random thing like, I need to go somewhere, or I'm feeling hungry. He doesn't stick to one line of thought or one line of conversation which we are trying to have with him. He tends to deviate from whatever is happening around him. So, what are the causes? Probably this may be important for you as well, for your evaluation as well. So, there are certain causes. For sake of easy remembering, I have written it as delirium itself. So, D for drugs. Any person who is under the influence of some sort of drugs, and many a times because there is withdrawal from drugs as well, right? So the person has been a long-standing habituated to alcoholism, or other forms of drugs, and now he's trying to stop it. So there will be withdrawal, like we have already mentioned. E for eyes and ears. Now, the only reason why we are able to be oriented is because of our eyes and ears, right? We are able to see what is happening around us, so we know our surroundings, and we are able to hear. That's why we are able to be oriented what is happening around in our immediate surroundings. Now, many times in elderly patients or in patients with other some kind of diseases, slowly due to some abnormalities of the ears or the eyes, what you can see is that there is no visual perception or auditory perception. So when this starts happening over a chronic period of time, the person starts getting disoriented. He's not sure about whether it is daytime or what time of the day it is. So when these sort of things start happening over a long period of time, the person starts becoming disoriented or disorganized in his thoughts. Simple things, solutions like getting a spectacle or a hearing aid may solve the problem. Low oxygen states, obviously we all know that we can't survive without oxygen. So whenever there is an oxygen deprivation or reduced oxygen due to whatever reason, it may be a heart attack where the heart is not pumping enough blood, or it may be a stroke within the brain, or it may be an embolus inside the lungs because of which oxygen exchange is not happening into the blood. So in such circumstances, this can happen. In case of infections, wherever there is a focus of infection, basically. So many a times we may have some, for example, diabetic patients, they may get some small injury. They will not be aware of it because their nerves are so much damaged that they can't feel any injury which may happen to them. So this injury gets infected and then it spreads through the blood to all parts of the body. This kind of infection, if it is there, it can cause a delirium. In simple terms, what do we call this as? Septicemia or sepsis. Very true, very correct. Next is retention. Mind this, okay? In palliative care settings, one of the major questions which we always ask is, have you passed stools today? Have you passed urine today? Extremely important questions. Funny in some situations where when we ask, the first question which we ask many a times ends up being this. One of the reasons is that it has got a direct bearing over the functional status of a person. If there is retention of urine or stools, there is a high adrenergic hyperdrive within something called as an adrenergic hyperdrive within a person's system. So when this happens, what happens is the delirium can worsen. Okay, we'll look into it further. That whenever there is basically delirium happens because of some chemical imbalance which happens, and whenever there is an adrenergic drive, there is a excess of certain hormones which are released into the bloodstream, which leads to worsening of the delirium. So what we try doing, the treatment will be to ensure that the person passes bowel or passes urine, or you put that catheter if there is a urinary block, etc. Next is I. I is for ictal. Ictal means this is basically some seizure which is happening. Okay, some seizure which is happening. So whenever immediately after a fits or a seizure happens, what happens is the person will be in sudden confusion. He doesn't know where he is, what is happening around him. He doesn't remember suddenly what was happening with him. Sometimes they pass stools and urine also on the spot. So this kind of a state. So ictal, basically post-ictal state, can also cause confusion. Again, for uncontrolled pain, always remember it is not just palliative care. Many of the times it is pain and palliative care. Okay. So if the person is having uncontrolled pain due to whatever reason, it may be a cancer related illness or it may be a non-cancer illness. Any of the state, if there is uncontrolled pain, it can lead to delirium. Metabolic causes, if there is glucose, sodium, potassium, magnesium imbalances happening, either hypo or hyper, that is either less or more, it can lead to delirium. And finally, S. S is subdural hematomas, right? So subdural hematoma means there is some collection of, due to whatever reason, either a fall or some trauma, there is some blood collection which is there inside the skull. So whenever that happens, it is called as a subdural hematoma. Also remember that neurotransmitters, and based on the kind of neurotransmitter which you suspect is the cause of the delirium, you may have to start on certain medications. And when you start on these medications, it may have some effect on the delirium. So what is the burden of delirium? Remember that in about 30% of hospitalized patients, especially if the patient is in an ICU, okay, and towards end of life, when the last few days of their life, when they are passing from this life, 85% of such patients may have delirium. So in hospitalized settings, especially in ICU settings, you know that the patient is continuously inside the ICU, the lights are always on, the monitors are always beeping, so many sounds happening, people are always walking around. So in between all this, where do you expect the patient to be oriented, right? So always remember, very, very commonly seen in ICU. And other reason is in ICU, most of the patients are there because there are so many kinds of illnesses because of which they have ended up in an ICU. So as you saw the causes, delirium causes, they may have multiple causes because of which they are having delirium. Right. So what is the impact of delirium? One is there will be a functional decline. Okay, so whenever the person, suppose an elderly person, as he is growing old, his functional status decreases, right? He is not able to move around as much, not able to do as much activities of daily living, and not as much as balanced while walking as well. Now, this person has a fall. After a fall, this person has a fracture. A fracture neck of femur, basically, a neck of femur or a hip fracture is something very commonly seen. So, once this fracture develops, the person, many a times, we won't go for any active procedure for this patient, like, because they're elderly, they may not be able to tolerate an extensive surgery. Even if they do the surgery, for whatever reason, they may not recover that soon from the surgery. So many a times these people end up being immobilized. And once they're immobilized, again there is a functional decline. And then the vicious cycle continues. Many a times there will be incontinence, okay, incontinence of urine or of feces due to different pathological conditions. Um, Hydration and nutrition, if suppose the person is not well hydrated or his nutritional status is poor, in these statuses, again metabolic disturbances can happen. And in a person having delirium, sometimes you may want to feed the patient, okay, out of your concern for the patient, or the concern of a caregiver, they want to give food and water to the patient, but because of abnormal behavior, what do? They'll just hit the plate and throw the food away, or they may get the glass of water from you and put it on your face itself. These kind of behaviors may happen. So impact of delirium, again their functional status will decline, nutrition will decline, right? And then they end up being an emotional burden is usually what we think of is in terms of the caregiver has to see. Just imagine somebody, your loved one, who has been with you for many years, 30-40 years, somebody like that undergoing a disease and having abnormal behavior in such a way that many times they are not able to recognize you. Many times they may be aggressive towards their loved ones. They may even tend to be violent. So it ends up being a big emotional burden for the person who is seeing all this. And remember one thing, being in delirium also causes distress to the person themselves. Okay, keep that in mind as well. So why delirium? Why does this actually happen? Even if we told all the causes, but then why does this happen? To be frank, the mechanism is still under investigation. It is very poorly understood. One of the things which is hypothesized or is being thought of is that there is a system called as reticular activating system. We have got a brain stem. Inside the brain stem, there is a reticular activating system. So this activating system, like the name suggests, it keeps you activated. And there are certain neurotransmitters present over here also. So what happens if this activating system gets dull, you also become dull, right? So whenever there is some issue in the reticular activating system or there is a chemical imbalance, majority of the times there are only two neurotransmitters which is implicated. One is acetylcholine and next is dopamine. Very commonly, all of us have heard. That is deficiency of acetylcholine or there is excess of dopamine. These are major neurotransmitters which if not given, if it's not functioning properly, can cause psychomotor abnormalities. Dopamine is a major neurotransmitter and it causes, if there is less dopamine within the brain due to some changes which happen inside the brain, one major disease happens, which is a very common disease, Parkinson's, right? So look over here, in delirium, there is excess of dopamine, too much of dopamine inside the brain. Okay. Now, coming to the next point, remember one thing, despite of all these things, not all individuals exposed to the same insult will develop signs of delirium. For example, if I may come and pinch you, okay, if I come and pinch you, some people, if I just go and touch, they will shout. Some people I have to touch and press, then only they will shout. Some people I will pinch very hard and still they will not shout, right? So not all individuals exposed to the same insult will develop signs of delirium. Okay, let's understand this a little better. So here you can see Right. So there are certain individual risk factors and there are certain triggering factors. Okay. Now look at it. Suppose the individual risk factor, if it is low, what do you mean by individual risk factor? That means that something is wrong with myself right now. Now, suppose issues with myself is low. For example, I am young age right now. Okay. So chances of me having some illness is less. I do not have any dementia like illness, right? In elderly, because of brain becoming shrunken, they may start developing memory loss. That is called as dementia in simple terms. So there is no dementia, and I don't have any chronic diseases like diabetes or hypertension. I don't have it yet. Okay, so all my individual risk factors are low, right? Are low. Now, if a person like me who is having low individual risk factors, if I have only if I have some very high, very severe, very serious triggering factor, only then there is chance of me going into delirium. Okay. For example, I go into sepsis, like you said, my blood is completely infected. Sepsis, it can be a life-threatening condition. I underwent a high-risk surgical procedure, right? That is, there is some issue in my brain, and a neurosurgical procedure had to be done. So now, high-risk surgical procedure, or some sort of drug toxicity I got right now. Some drug I took excess in amount. Okay, now I'm in toxicity. So for a young person or for a person with very less individual, very low risk factors, for such a person needs very high triggering factors. Okay, but let us look at the other side. Suppose it is an elderly person. It is an elderly person having some chronic illness, or they're having some memory loss, or they're having multiple diseases. For such a person, something as small as a loud sound or a bright light or a change in their environment. They started living in a new house. You wanted to do something for your elderly parent, and then you built a new swanky house, and you told, as a surprise, you told them, you blindfolded them, okay, and you took them to the new house and told, now onwards, this is your new house. They will act confused and they may even start abusing you. Okay, so something as simple as change in environment can also be a triggering factor for a person who has high individual risk factors. So as we have already said, in certain situations, the delirium threshold is lowered. That is, if these conditions are there, the person can easily go into delirium. So extremes of age group, suppose it's a very young child or it's a very elderly person, the person is having some dementia or memory loss, the person is having hearing or visual impairment, the person is having alcohol abuse, the person has got a history of depression, the person has reduced physical activity. Okay, so if these situations are there, the delirium threshold is lower. That means easy, small triggers can lead to delirium. Now, triggering factors for delirium. One, as I told you, you wanted to gift a new house to your parent, you did a change in environment and they started abusing you. Change in environment. Unfamiliar excessive stimuli. They are lying down somewhere and there is a bomb blast outside. Unfamiliar excessive stimuli. Okay. General condition deterioration. That is, they are growing old, their intake is less, their physical activity is less, so their general condition deteriorates. Uncontrolled symptoms, like we had said, uncontrolled pain. Primary or secondary brain tumors. Primary means it is a brain tumor. Secondary means it is a lung tumor, but it has sent some deposits into the brain. So primary or secondary brain tumors. So directly it affects the brain function. Paraneoplastic syndromes. Paraneoplastic means cancer. So related to cancer, certain types of cancer, some hormones or enzymes may get released into the bloodstream, which goes and affects in the brain and leads to paraneoplastic syndromes. Biochemical disturbances, like we already told, glucose abnormalities, sodium, potassium, magnesium abnormalities within the system. and drug induced. Of course, if you are on some kind of drugs, these drugs need not be only illegal drugs like I have been saying so far. It can be some legal drugs as well. Okay. If the person is in withdrawal states like alcohol withdrawal, if the patient has an organ impairment, for example, kidney or liver is not functioning due to liver failure or kidney failure they have reached, so there will be chemical imbalances in the system which leads to delirium. If the person is sleep deprived, all of us, if we are awake for one night itself, the next day we'll be disoriented, right? So due to many of the kinds of illnesses, the person is sleep deprived. They are not able to sleep at night. So sleep deprivation can cause. Then some major surgeries or if there is a trauma as well. These can be triggering factor. What are the types of delirium? Delirium can be hyperactive, like I said, aggressive, violent behavior, abusive behavior, or hypoactive as well. Hypoactive would mean that the person is not at all active and he is just sitting somewhere relaxed and not moving around much. Okay. And sometimes it will be mixed. Sometimes it will be hyper, sometimes it will be hypo. Usually it is a mixed type of delirium which is seen. Here you can see that there is on the upper end, the person becomes agitated, and at the lower end, he'll be withdrawn as if he's in depression. So you can see a kind of waxing and waning pattern which keeps happening, right? So too much of delirium, if it goes above, it becomes hyperactive, it comes below, hypoactive. And this pink line in the center is called as the normal state. So in between, he will be having periods of normalcy also. So this will send the person into a lot of distress because they'll start wondering that sometimes so he behaves very normally, sometimes he behaves abnormally. I'm not understanding what is happening. Please help me, doctor. Right. So how do you assess delirium? Many times, suppose there are certain predisposing conditions because of which the patient is going to get a delirium. Most of us would prefer hypoactive delirium. Hypoactive would mean, okay, if he wants to get delirium, let him have hypoactive. So that he is simply sitting somewhere and not being abusive, not being aggressive, and not bothering somebody. But remember one thing, that as far as this is concerned, in hypoactive delirium, the person can in future go for worsening much more. It will be much more worse that the person is going in for a hypoactively thinking about his disease condition, and so he is being quite maybe little depressed about things. Don't treat delirium So what is confusion assessment method? The confusion assessment method has got 4 features. Out of these 4, 2 have to be there and either of the next 2. So one is it has to be an acute onset. Like I said, acute onset need not mean that it has to be within a few minutes. It may be a few hours or even a couple of days. Or it has to have a fluctuating course. Like I said, sometimes it is normal, sometimes abnormal. Fluctuating course. The patient is having these are there, then we will call it as the patient is having delirium. So acute onset and fluctuating course, we said, is being confused. They may be admitted, but they will say that, no, I am not in the hospital, I am at home. Or they may be at home and they will say that they are in the hospital. And they may say that they are seeing things which are not there. They'll say that there is somebody standing behind the curtain with a knife waiting to kill me. These kind of things may be there. So acute onset and fluctuating course, inattention. How do you check for inattention? So you can say a digit span. For example, 1, 2, 3, 4. You will tell the patient to repeat 1, 2, 3, 4, but backwards. So they have to say 4, 3, 2, 1. Okay. So you can make it difficult for them. You say 5, 6, 7, 8 or something like that. Okay. So they have to correctly say it backwards. or you tell them that say from Sunday to Monday but backwards, okay, or you start from December and tell till January. So everything backwards. If they are unable to say that, we'll say that they are not having attention or they are having inattention. Disorganized thinking, you can simply ask which is the current year or which day it is today or where are you right now. An altered level of consciousness. Some of them may be very alert, very vigilant. Some of them may be lethargic. Some of them may be stuporous or comatose. So altered level of consciousness, right? So that is how we look at CAM, that is CAM. Now there is another method as well, which is called as the 480 method, which is a very simple way of looking at it. Okay. Here also it is having a similar way of looking at it, like alertness is looked at, the age and things like that of a person is looked at, the current, what if he's able to correctly answer the age, current year or his date of birth, if he is able to give correct answers, if his attention is proper or not, or if there is acute fluctuating course. Now the advantage of this is if the score is 4 or above, the person is having delirium. So you need not ask all the questions. You can see the first question under alertness, the mark is given as 4 if the alertness is clearly abnormal. So you look at the person and he's behaving abnormally or having abnormal alertness, directly he gets a score of 4. Then you don't need to look at inattention and disorganized thinking or something like that. Directly you give a score of 4 and you conclude that the person is having delirium. Easy bedside test, okay, so that you don't have to spend much time as well. So how do you manage delirium? Remember always that because there are so many causes of delirium, always you correct the correctable cause. Whatever is the cause of correct. It may be as simple as getting a spectacle or getting a hearing aid for a patient. Okay, it may be as simple as that. So always keep in mind, correct the correctable. Next is you always look at non-pharmacological methods of treatment. That is, you don't directly look at drugs to give drugs. And only after the non-pharmacological is tried, then you will go for pharmacological management. That is, you look at the using drugs. Now remember one thing, there are certain conditions which can mimic or act like delirium. I'm sure at least some of you must have thought of, how will I know whether the patient is actually having a hypoactive delirium or he's in depression? How will I actually know that if the patient is having delirium or he's having some form of psychotic break? Okay, so you can look over here. Do you expect depression to start suddenly? There'll be some background to a person going in for depression, right? So is that the situation with delirium? No, in delirium, the person may be all right till yesterday or till today morning, and by evening he is worsened. So you can see in depression, acute changes are not there. Okay, altered consciousness is not there. They will be alert. They won't have any disorganized thinking. Now, some people may have dementia, that is some loss of memory. Again, it won't be acute. It will be slowly happening over a period of time. Now, again, a person who is having psychosis, a person having psychosis may not have altered consciousness. He'll always be alert. Okay, he'll be alert. There is no waxing and waning pattern usually seen. So these are certain of the parameters through which you can differentiate between delirium, dementia, depression, or psychosis. Right. So what are the non-pharmacological measures? You may be thinking why a nurse should know this in so much detail. Because you people are the ones who are there with the patient for a majority amount of time. You are the ones who are closely interacting with the caregiver and the patient for longer periods of time, doing so much for the patient, whether it be giving food or giving medications or ensuring that some injections are given or asking for the general well-being. So for everything, the sisters or the brothers are the ones who are always there as a first line of contact. So non-pharmacological measures, there are many of them, and it is of mighty importance before you go for drug related therapy. So let's start looking at it one by one. So there are some of them which will be nearly 7 of them. There are more methods as well. Let's look at some of them. How can you optimize sleep-wake pattern? A person due to his illness has stopped sleeping at night and is awake during daytime. How do you expect the person to be normal? Obviously, he will start becoming disorganized in his thoughts, right? So you have to increase the exposure to sunlight. Suppose a patient comes to the ward, new admission, you know there is a history of delirium in your primary assessment. You have to give a bed which is closer to the window, because when the window is hitting, when he's lying down near the window, there is sunlight during daytime and there is darkness at night. And mind you, only when darkness happens, there is something called as melatonin which is secreted inside the brain, because of which we start feeling sleepy. This is one of the reasons why we want to have lights off so that we can sleep comfortably. You should have a low level of light and noise. Do you expect a patient to sleep well in the ICU? I don't think so. Then have some sleep protocols. Okay, some people, they want to have a slight head massage before they go to sleep, or they want to have some warm milk with some turmeric in it before they go to sleep, or they want to listen to some calm music before they go to sleep. So identify some sleep protocols for the patient, because of which the patient can go to sleep properly and you can optimize the sleep pattern of the patient. Next is patient orientation. Many a times the patient may not be oriented. Like we said, he may keep thinking that he is at home, or he may think that he is in hospital or whatever. So you have to keep explaining to the patient that where he is, what happened to him, who are the people who are with him, who are you to him. These things you have to keep explaining to the patient. Can any one of you tell me a movie where a person had to take so much help of keeping on orienting himself? It is our Amir Khan, who had written stuff all over his body so that he can remember and be oriented to what he was. So when you don't have to scribble things on the patient's body, okay? Otherwise, you may be sued, or the patient, non-delirious patient, may also have abusive or aggressive behavior. So what you can do is have a whiteboard in front of the patient where you can write down things for the patient, and maybe which year this is, which hospital this is, what location he is in, and always have a clock so that the patient can look at the time always. Communication. So communication is good in the sense we need to ensure that the patient is able to communicate with us properly, and whatever we are communicating is being received well by the patient. So eyeglasses and hearing aids, okay? Dentures, that is so that the person can communicate properly. Otherwise, you know how old people talk, right? I'm not going to mimic it right now, but without dentures, also communication suffers. Encourage mobility. Mobilize the person as much as possible, okay? If the patient is lying down most of the time, ensure that at least for the meals, he's sitting up. Avoid using restraints, physical restraints. Many a times out of irritation, we tend to tie the hands and legs of the patient to the railing of the bed. Would you like your hands and legs to be tied due to whatever reason? If suppose for whatever reason I tie your hands and legs, what will be your reaction? So you're going to be angry, you're going to be anxious, you feel harassed, right? So just imagine that a patient who is already not feeling well, who is already in distress, who knows that something is not right with him, and you're tying his hands and legs to the railing. On top of that, there'll be all these monitors beeping and people are laughing and giggling around. He's going to definitely going to have a hard time, right? So avoid using physical restraints as much as possible. And minimize use of catheters, because catheters themselves, one, it will reduce mobility. Two, catheter can cause infections as well. Next, as I told, monitor bowel and bladder habits. Every single day, you should ask your patient, have you passed stools? Was it difficult or not? Do you feel still uncomfortable? Is there any urinary retention? Do you need to catheterize this patient? These are things which you should consider on a day-to-day basis and treat them accordingly. Provide support and education. Many a times, looking only at the family, looking only at the patient, we forget about the family. Many a times we need to educate and support the family members as well. Extremely important, because even when the doctor moves away, even when the nurse moves away, it is the family member who is there 24/7 with the patient, right? So, so counseling the family, educating them about the situation, that you think the cause of delirium is this, so we need to look into some investigation. It may take some time. We may have to start some medication, or we are going to try without medications first. So during the meanwhile, it will be slightly difficult for you. I can understand that. But just do not get angry on the patient. Reassure the patient in a calm voice, reorient them, and just be calm so that you don't cause any further distress. And like it is with all situations in life, there is absolutely no point in getting angry and agitated yourself. So have a calm mind, understand the facts which is happening with the patient right now, and deal with the situation. Now coming to pharmacological management. After you have tried all these things, nothing is working. Now you want to give, doctor, I am not able to manage this patient, just do something or discharge the patient. So no, I'll give some medicine and see. So we come to pharmacological management. So there are 4 situations in which you have to consider giving medications. 1, non-pharmacological methods have failed, or the patient is severely distressed. You can see he is angry, agitated, aggressive, or whichever way. He is distressed basically. Or the patient is a risk to themselves or to others. They may cut themselves or they may cut you, or the person who is lying down on the next bed. And 4, they are having agitation. So basically, 2 things. 1, distress due to perceptual disturbance. They are feeling that somebody is lying down beneath the bed and he's having a gun in his hand. The moment, sister, you go, he is going to shoot me. Or second, if there is agitation, angry, agitation, abusive language, because of which it is causing issues. So basically 2 target symptoms: perceptual disturbances like hallucinations and agitation. So the class of drugs which we use for this kind of behavior is called as antipsychotics. Mind you, just because the word is antipsychotic doesn't mean that we will give the medication only when the patient is in aggression. You should equally identify when the patient is in hypoactive delirium. That is, he's having some abnormal behavior, abnormally depressed, abnormally quiet. Suddenly, he's having these kind of things. Then also you may want to start them on antipsychotics. And the drug of choice usually is a drug named as haloperidol, which can be given orally. It can be given IV. Now, if nothing is possible, you can also give subcutaneously, that is below the subcutaneous tissue. Now, benzodiazepines. You would have heard the term benzodiazepines. You would have heard the terms midazolam and lorazepam. Whenever you want the patient to go to sleep or become less active or become less aggressive, you use these drugs. But mind you, again, benzodiazepines should be used only when there is hyperactive delirium or when there is aggressive behavior. Okay. Otherwise, as far as possible, for hypoactive delirium or whenever you can manage with just haloperidol or other medications, you will not use benzodiazepines, because benzodiazepine can worsen delirium as well. So always have this in mind, that benzodiazepines can worsen delirium, and you will use it only and only when there is hyperactive delirium. That is, the person is having aggressive behavior. So there are certain antipsychotics which we very commonly use. And the ones which I have highlighted over here, or I put in the red box, are the ones most commonly used. That is haloperidol, quetiapine, risperidone, and sometimes olanzapine as well. Now you can see that there are certain side effects as well for these drugs. Some may cause lot of sedation, that is they feel after giving it, the patient's family members will tell that the patient is sleepy all the time. And some may have some worsening of Parkinson's, because as we already told, there is excess of dopamine, right? So there are certain medications because of which it can increase the delirium because of the effects on dopamine. So there are certain side effects. Just know that there are certain side effects as well which can happen with use of drugs. So what is our conclusion? The conclusion is always correct the correctable. Whatever cause you can correct it. Go for non-pharmacological management as far as possible. Many times a multidisciplinary approach may be needed. Sometimes you may have to take the help of a psychiatrist to ensure that this is delirium, but the patient doesn't have some underlying psychological illness. Communicate and take the caregivers along. Always take the family members along. Make them understand. It may be a little time consuming, but it will give you a lot of satisfaction to see the way the family members will handle the patient and the situation also. So they understand that this is going to take some time. So every time something abnormal happens, they will not end up calling, sister, he's behaving like this, sister, he's saying like this. To avoid that kind of calling also, you need to communicate with the family members always. And lastly, always identify hypoactive delirium. Like many of you told, you may want the patient to be in hypoactive delirium preferably, but a person in hypoactive delirium may not get treated for long periods of time, which will lead to worsening of their illness and will give severe distress. And more importantly, towards end of life, it will give a bad, distressing death to the patient. So always identify hypoactive delirium and treat it.
Okay. Thank you. Anybody have any questions regarding this? Please ask. Any questions or any clarification regarding this? Anybody? Sangeet, if they don't have any question, please can move on to the case presentation. Joshna will be presenting a patient story. Please, carry on.
Okay.
Shall I start now?
Yes, you are.
Okay. Good evening, everyone. This is Joshna. Today we are going to discuss about one of my patients with the diagnosis delirium. My patient, 81 years old, male, with the diagnosis UTI with acute confusion. His presenting complaints when he was brought to the ER department, he had the presenting complaints of high-grade fever, complaint of pain in the lower abdomen. He had poor appetite and vomiting. Also complaint of nocturia and dysuria. And the patient showed symptoms of confusion, disorientation. History of the illness, my patient, 81 years old age, he is suffering with hypertension from past 20 years and he is on medication. He was brought to the ER department on 23rd July and they complained of low-grade fever, dysuria and poor sleep from the past 3 days prior to the admission. And on the day of admission, the patient had high-grade fever with dysuria, abdominal pain, vomitings, and he had become confused and disoriented. That's when the patient was brought to the hospital. Next slide. On examination, the temperature was around 38.3 degrees Celsius and the blood pressure was 157/95, pulse 112 beats per minute, respiratory rate 30 breaths per minute. Oxygen saturation was around 94-96. His GCS score was 13 and he had a cloudy and strong smelling urine. Then the significant investigations and all, there was an elevated WBC count and also a positive urine analysis where there was plus RBC and pus cells were found. Also, there was a positive urine culture which yielded E. coli growth. Now, the psychological aspects of the family, the patient lives with his family, with his wife. He's a non-smoker and he receives an old age pension from government. At present, there are no caregivers because both the children live in different cities because their job, because of their job perspective, and they are not that much supportive to the old parents. And the patient's caregiver, his wife, is very much apprehensive about his condition because there was no support. And also herself, she suffers with diabetes and arthritis, and she's on medications. The patient is receiving paracetamol, received paracetamol stat on the time he was brought. Then he was prescribed paracetamol 500 mg TID, injection Pantop, then injection amikacin and lorazepam was prescribed for the patient. The main concern of the patient and his wife is main concern is that to manage the fever and body pains, there was a risk of pressure ulcers, also weakness, falls and fractures because the patient is disoriented. There is a severe financial crisis in that family and also the caregiver's health was also affected. So these are the main concerns for the patient and his caregiver. The overall summary, an 81 years old male diagnosed with UTI and presented with signs of moderate delirium. He's known hypertensive with poor health care, deprived financial support and psychological support. The discussion points now is what are the immediate and long-term needs of the patient and his wife? Does the patient's wife also under the radar of providing palliative care? And how can we support the family comprehensively? Thank you.
Thank you, Sister Joshna, for the wonderful presentation. So I think the presentation is clear to everyone. If anybody wants to need a clarification regarding this patient story, please ask us. So otherwise, we can move on to the discussion point. So I think the presentation is clear to everyone. So we can discuss the discussion point. Okay. So from today's class, you have understand that there are lots of predisposing factors and provocating that precipitating factors of delirium. So from this patient story, please tell me what are the precipitating factors or what are the predisposing factors of delirium from this patient story? Or what are the causes of delirium which you have identified from this patient? You can unmute yourself and talk, or you can put your answers in the chat box. So, or please respond. We all nurses, please respond. So, delirium is one of the most common symptoms which we have seen many times in our practice, especially in ICU settings. So please ask something, or you can contribute your suggestion for these patients. We need to help Sister Joshna for helping this patient. So she came with the discussion points. So please think about this and give your suggestion. Anybody? Nobody is there, huh? So there are 24 participants are sitting. So please respond something. Do you think this patient needs palliative care?
Yes, ma'am.
Yes. So Sister Ashwini said age and family background may the cause. Okay. Any other points? Yes, Sister Stella said yes, definitely this patient needs palliative care. Okay. So if these patients come to you with these kind of problems, how will you manage? So age is the only thing you have identified from this patient story? Age and family background? So Sangeet, please go back to the patient physical problems, present complaints. Yes. So these are the present complaints. He was having high grade fever, pain in the lower abdomen, poor appetite, vomiting, nocturia, dysuria. So these are the presenting complaints. Now tell me, so what are the problems? May cause from these symptoms, what are the problems? The patient is also having confusion too. Huh? Pain, yes. Uncontrolled pain can cause delirium. So definitely this patient needs pain management. Then fever. If there is any infection there, definitely fever is a symptom, no? Pyrexia, yeah. So fever, yeah. Fever is one of the problems. So if there is any problem there, fever is there, no? So if there is any infection, so if they're complaining of fever, definitely you have to think about whether there is any chance of infection. So this patient is having UTI, no? Definitely this patient develops fever and rigor and chills. So these fever, these kind of problems can develop. Then, so age is another factor. And what about bowel pattern? Sister Joshna?
Ma'am, he was
Electrolyte-
but once the fever started, he had
Okay, no
his
history of
bowel.
constipation, right?
No, ma'am. No, ma'am. No, no.
No. Okay. So Usually so these are the two problems, because chronic constipation and the retention of bladder is also one of the most common problems. The patients develop delirium. So when a patient comes to you with delirium, definitely you have to try to identify the cause first. You have to treat the underlying cause. So then only you have to think about the medications. Try to treat the patient with the non-pharmacological management. And then if that non-pharmacological management is not help, then you can think about the pharmacological management. From this patient story, this patient is having UTI. You have to give some antibiotics and control the infection, so that we can able to reduce the infection. And when the infection level is reduced, definitely the fever is also comes down. And you have to identify why this patient is having poor appetite. So what was the problem? Why the patient is not having a good appetite? How to identify that? Is there any particular problem? Mr. Josna?
Ma'am, he was having this nausea and vomitings, ma'am, from the time this fever started.
Okay, nausea and vomiting is there. Okay, maybe because
So that's
of that
what,
UTI.
yeah,
And loss of appetite, poor appetite.
because of nausea and vomiting,
That because of nausea and vomiting,
he's
he
not
is
able to
not
take
able to take
proper
it.
diet, ma'am.
Oh, okay, so yeah.
Yeah, yes, ma'am.
So appetite is there, but not able to take it properly because of the nausea and vomiting, right?
Yes, yes, ma'am, yes, ma'am.
Okay, fine. So here you have to think about the patient age. You have to think about the patient that problems, and then you have to try to control the problems. With, for example, as I mentioned earlier, if they have a fever, you have to try find out whether the patient is having any kind of infection. So here this patient is having UTI. Maybe because of that, the patient can develop fever. And if they have these kind of problems, they definitely nausea and vomiting also can develop. And dysuria is there, pain in the lower abdomen is there, maybe because of UTI, and pain is also a precipitating factor. So these all symptoms can cause the patient will develop confusion and delirious stage. So now we move on to the discussion point. Please, Sangeet, please move on to the discussion points. Sangeet, I need discussion points. Yes. Okay. So what are the immediate and long-term needs of the patient and his wife? So, I would like to hear from the participant side. So what are the immediate and long-term needs of the patient and his wife? This patient's wife is also elderly, because we know that this patient needs his wife is also need palliative care. At the same time, she needs to look after her husband too. So how will we manage if these kind of situations, if you are facing? So how will you manage? Any idea? So they have a financial constraints. There are a lot of psychosocial issues too. So Joshna has mentioned about his children, whether they are staying nearby or far away. So I would like to know more about that patient's family. Poor connection. Okay, Joshna has poor connection. So I
Ma'am,
assume
children
that
live far off,
network.
ma'am.
Okay, far
Children
away.
live far off, ma'am. They live in different cities, ma'am.
Okay. Did you talk to them?
We have spoken through call, ma'am, but they were saying some reasons like they are not getting leaves and all. I mean, through their talks, I can understand that they are not much supportive to them. Like they are telling we are not able to get leave and all. They're telling reasons,
Oh,
ma'am.
okay. So what about the family background? Did you talk to the patient and family?
They live in
The
different cities, ma'am.
patient? No. I am asking about his patient and his wife.
Patient in this.
Yeah. So what they are telling? So their children saying like maybe some reasons will be there. So why they are reluctant to come and take care of them? So definitely they have their own reasons, but from the patient side, we have to identify. You have to understand that from that background, what was the family background and whether they are good relationship or any bad relationship, if there are any family problems. So that kind of things we have to find out from the patient and his wife. So, did you find any problems from there? Any maybe broken family or any issues? That kind of things I am asking.
No, ma'am. They don't have any such broken family and all. But the only thing is, parents were telling that the children are very busy. They often doesn't come to visit them. That's all. They don't
Okay.
show
Did they
any
empathy?
Yes, ma'am.
Okay.
Yes, ma'am.
So did they support financially?
Financially, they do support.
Okay. So okay, they financially support, right? They have two children, but they are helping financially, but they are not able to come and take care of them.
Parents.
So now you had mentioned about the financial crisis. What was that?
Yes, ma'am.
Yeah. So is there any financial
this
crisis?
man gets an old age pension. They just get an old age
Okay.
pension, ma'am, every month. And a little bit,
Okay.
both their children may send a little bit, but that is not enough for their medical expenses and also for their daily living.
Okay. So where are they right now? Whether they are in the hospital or they are
No,
in the
no, ma'am. It was long back. July they have got admitted, ma'am. So they got discharged
Okay.
after 10 days of treatment.
Okay. Now they are in their own house, right?
They live in a nearby place from our hospital. It 30 to 40 kilometers. Here now they are at home. Yeah.
Okay. Okay. Thank you. So, so how will you manage this patient? So we had treated their acute problems, and we had sent back to their home, and there nobody is there. Only two old age persons are there. Uh, so they both need palliative care. So from for that this kind of patients, how will you give care? Definitely, we all agree that this patient needs palliative care or supportive care, but we send them back and nobody is there. So now you have to think about the community support, and you have to think about the NGO who is running palliative. Maybe if there is any nearby palliative care centers there, you have to try to connect with them, and so that they will get care from that nearby palliative care center. Or you can try to identify volunteer or like a panchayat member or ASHA workers so who is willing to help them. Definitely, if you connect with them, definitely if they have a that time, if they get any time, they will come, they will go there and visit the patient, and they at least they can able to identify the patient problems and connect with the palliative nurses. So I understand that every in Kerala, we in every panchayat we have a palliative care nurse, and if they have any problems, like if ASHA worker will be identifying any problems from the patient's house, they definitely they will call the palliative care nurse and tell the patient's problems, and after that the palliative care nurse or a JPHS or a ANM nurse will be go there and visit the patient problems and give the support as much as she can, and then she or he will be connect with the medical officer. So that is why that is what in Kerala we are doing in the government setting. But we have a lot of NGOs who is running palliative care here. So definitely, if these kind of patients develop in a community, that nearby that palliative care unit will be helping the patient. And in the meantime, we will try to identify that volunteer who is willing to help these kind of patients. They can also in between they can go there and see the patient problems, and they can able to help the patient and family. So that and also definitely these patients will have a social isolation and family isolation. There will be a isolation phase. So if possible, if anybody goes in between to them and listen their problems, definitely they have lot of problems. Nobody is there, and two children are staying away, so nobody is there to listen their problems. If anyone who is that helping, maybe who is willing to help them, go there and listen their problems, at least they can able to share their problems and express their emotions, so that they can get at least that mental relief. So these kind of things you can do it. Did you have any palliative care centers nearby, Joshna?
Here, we don't have, ma'am. We are just follow up to that patient's family house. There are no palliative service units.
Oh, you
They
don't.
come all along here to our hospital whenever there is a need. That's all.
Okay, okay. Thank you. So from this patient story, we have to understand that we need to spread awareness among the community and make them sorry. So make them understand that the importance of palliative care in the community. If we have a that NGO like that, or the community support, maybe community-based organization like that, there, if these kind of things will be there, so that team will be able to support these kind of patients. So the important points we need to understand that to spread the awareness about palliative care, especially among medical practitioners also, and also community is also understand the needs of palliative care, so that community person, if they need any problem, these kind of elderly persons there, definitely they will be able to connect with them, and they can give some kind of support. And again, these three questions: does the patient's wife also under the idea of providing palliative care? Yes, definitely yes. But she needs palliative care, but unfortunately, she is the only person to give palliative care to her husband too. But she definitely she need a community support. And how can we support the patient family comprehensively? So how do you think? So what do you think? So from as I mentioned earlier, so give some, maybe you can give a take a phone. You can say even if they get a call from you, definitely they will be feeling better, happy. So okay. They definitely they will feel happy. So I have many experience like that. So if we call them and assess them, find out how are you and do you have any problems. So we are, if you have any problem there, you please come to us, we are here to help you. These kind of positive things will make them feel happy, because they might be thinking like, okay, they are there to help us. So these kind of things. So okay, so Lizzie ma'am said we can visit them. Is there nearby you this patient's house? So if there is any palliative care center nearby, definitely you can connect with them. So please tell to Sister Joshna, she might be able to connect with the palliative care centers.
Yes.
So
Okay.
that the patient, the patient get full support. So here you have to think about the physical problems, psychological problems, emotional problems, and spiritual problems. So these all the four aspects they will be suffering. So if they have a psychosocial issues there, from this patient story, we understand that. So there are a lot of psychosocial issues, spiritual issues also there, because his children are not there, so they are living far away. So these kind of things will be affect. These kind of things will be affecting the patient that spiritually also. So if you can able to spend maybe at least 15 to 30 minutes, the patients, please sit with them and listen their problems. At least they can able to share their emotions. Any other points want to discuss? From the chat, I have seen one patient. So Stella sister said the patients can be put temporarily as as inpatient palliative care unit. Yes, he was. Sister Josna said he was admitted in their hospital for 10 days, and his symptoms are controlled, and then they sent them back. Definitely, if they have a needs, these kind of needs, definitely you have to think about the inpatient settings and try to control their problems, and then you have to think about the home care thing also. Once you send back to their home, if you have a home care unit there, you can do the follow-up. Otherwise, you can connect with the other nearby palliative care units. So, and another question, one more question I have seen in the chat box. So how does poor eyesight cause delirium? Not. So if they have a poor eyesight, there it doesn't cause any delirium. So these kind of problems can cause delirium. You have to think about that infection. You have to think about the electrolyte imbalance, like dehydration, hypoglycemia, and if there is any brain mist there, so that can cause delirium, and also restraints, physical restraints. From the class, you have understand well about the problems and causes. And urinary retention and constipation. So these are the common problems, and these can cause delirium, because if they have what you have to understand, that if they have a delirium develop, the family members can be think about, oh, the patients can develop, the patient is having madness. So this is not a madness. So this is the important message you have to convey with their family. So, this is almost all the delirium we can able to reverse, but except in terminal delirium. So, terminal delirium there we can't reverse, but all other delirium we can able to reverse. So, if they have developed these kind of especially delirium, definitely the patient family will be thinking about, oh, so the patient have some kind of mental problems, so they develop these kind of mental problems. These kind of thoughts will be there inside mind. So what you can do is, you have to tell them what was it, why these patients develop delirium, what was the cause of these kind of things. So reassurance is very important here. So you have to think about the reassurance, and give psychological support to the family. And if they are using any hearing aids or visual aids, definitely you have to think about that. That can also that, and also reorientation. So these kind of things can precipitate it. So if they have delirium there, as I mentioned earlier, you have to find out the cause first. Try to find out the cause, and based on the cause, you have to try to treat the cause, and try to manage the cause with the non-pharmacological management. And if not benefited, you can think about the pharmacological management. So the drug of choice of delirium is haloperidol. So haloperidol, you can give, the maximum dose of haloperidol is 20 milligram per 24 hours, over 24 hours. So and other drugs is also there, risperidone, quetiapine, these all things we can give, but the drug of choice is delirium. The drug of choice is haloperidol. So you can think about that. And as sir mentioned earlier, midazolam, these kind of things will precipitate delirium. If they have a hyperactive delirium there, give haloperidol first, and then you can think about the small dose of midazolam, like medications. Otherwise, these kind of medications can also precipitate delirium. Okay. Any other questions? Any other questions? So what are the legal issues should we pay attention to patient with delirium? So, Sister Stella, could you please tell us, is there any legal issue that maybe you are facing? Do you have any experience like that, or what do you think about that? I don't understand. So what are the legal issues means? So what kind of legal issues you could expect?
You would expect what kind of legal issues from this kind of patient? In sedating patients, okay. So we are not going to sedate this patient. So we are trying to reduce their symptoms. If they have a problem there, if they, for example, if a patient comes to you with delirium, severe constipation, but they when they comes to or urinary retention, from maybe because of the severe constipation, the patients can develop urinary retention. Both can cause delirium. Okay. So when a patient comes to you with these kind of problems in your outpatient settings, these are the two problems which the nurses can identify easily. Okay, without a doctor's help, you can identify. So you just tell them, okay, maybe the caregivers come and tell you. So since the last 2 days, he is having these kind of problems, irrelevant words. He was telling like that. These kind of the caregivers report will be there. So you just ask them, ask the patient if they are able to talk to you. Then otherwise you can talk to the caregivers and find out whether they have any problems, how to identify whether there is any infection history, any constipation history and retention of you can just feel the bladder and the abdomen and feel the bladder, the distended bladder, no? Feel that kind of things, you can easily manage. You can do, you can give put a nail cath or a Foley's catheter for relieving their bladder, and you can think about some enemas and manual removal of fecal matters, so that delirium will comes down. No, so these are the problems. If this kind of delirium is not controlled, so these are the problems. From this patient story, we can identify these are the problems. Sometimes after that, the patients can control, maybe can reduce the delirium. Okay, but if there is a terminal delirium there, we can't reverse. Okay, so that time what we do is we give some small dose of that midazolam, because we will try to manage with haloperidol, but if there is a hyperactive delirium there, we will manage give some midazolam or some sedations. So, but you have to talk to the caregivers first and make them understand that and take a consent. So if these kind of, maybe especially terminal delirium and hyperactive terminal delirium there, we can't manage sometimes. So that time what you can do is, for the patient's comfort, you have to think about that. But it does not cause any legal issues. From my 18 years of experience, I never have seen any kind of legal issues from this kind of that problems. So if they have a delirium there, terminal delirium there, definitely we will talk to the patient relatives and make them understand. And even the most of the patient may even in the end of life period can develop delirium. So we will try to control the delirium and make the patients comfortable as much as we can. I hope your doubt is clear. Mr. Stella, any other questions? Okay. So if you don't have any questions, we can wind up. Time up. Thank you, Mr. Josna, for the wonderful patient story. So if possible, please make a phone call and find out the patient's problems and make them happy as much as you are. Okay, thank you. Sangeet,
Okay, thank you, Shiva ma'am,
yeah,
for
we can,
the discussion
we
points.
can.
Okay, thank you everyone for participating. I request everyone to submit the feedback form also. Thank you. Let's see you in the next session.
Thank you.